Go ahead. Good evening. I am Indo from Panacea Biotec, and I welcome you all for the webinar on prostate cancer. And today we have with us Dr. Senthil Rajappa, Senior Medical Oncologist from Indo Cancer Hospital and Research Institute, Hyderabad. Dr. Senthil is instrumental in establishing the Diplomate of National Board Program in Medical Oncology at Indian American Hospital. Published more than 50 papers in international and national peer-reviewed journals. He has authored 4 books, chapters in clinical oncology and hematology. Sir has been principal investigator and co-investigator in more than 30 studies. Sir has delivered more than 150 lectures in international and national conferences. So now I request sir to take this session forward. Over to Dr. Senthil.
Thank you, Biotec, and good evening, ladies and gentlemen, all of you who have joined in for this webinar. The topic for today is titled as Positioning and Sequencing of Chemotherapy in Castrate-Resistant Prostate Cancer, and we will specifically discuss the role of cabazitaxel, which is one of those chemotherapeutic agents that we use for patients with advanced prostate cancer. So this is the outline of today's talk. We will start by going through the natural history of the disease and the present landscape in terms of the treatments available for this disease. We will talk about what is the evidence for cabazitaxel and where do you position it. We will compare hormonal versus chemotherapy depending on the clinical setting. Now, there is a general impression that cabazitaxel is a very difficult drug to use. We will check on whether it's truly a difficult drug, and then we will end by looking at the various sequences and discussing, is there really an ideal sequence that you can use for patients with advanced prostate cancer? Now, just to start with a little bit on a lighter note, this is the prostate cancer graph as far as incidence in the United States is concerned, and you will see that the incidence of prostate cancer was highest during the Bill Clinton era. And I don't have to tell you the relationship between Bill Clinton and the androgens. And we know that androgens are what prostate cancer is dependent upon for its growth, starting from the early stage to the metastatic setting and the advanced stage. Now here is a graph or a pictorial that shows you the natural history of progression in prostate cancer. Now if you want to divide it into 2 major parts, you start with what is called as the castrate-sensitive part and then the castrate-resistant part. Now please note that we are talking about castrate-sensitive and castrate-resistant. Now this is not equal to hormone sensitive and hormone resistant. You could be castrate resistant, but you could still be hormone sensitive because we know that testosterone can get produced in non-testicular sources also within the tumor and many other parts. And during the castrate resistant but a hormone sensitive phase, we will continue to use the various other hormonal manipulations for this disease. Now, during the early phase, you start with local therapy. You may or may not use androgen deprivation depending on whether that disease is called as a low risk or a high risk. You may have asymptomatic patients or you may have symptomatic patients, and the treatment will depend on the symptom level also. Now, during the castrate sensitive phase, you start with the LHRH agonist or and anti-androgens, and as they become resistant to this, they get on to a phase of chemotherapy, and then they become chemotherapy resistant, and you end at a point where they do not respond either to chemotherapy or any of the hormonal agents that you use for prostate cancer. Now, 2 things that we will not discuss today at all, we will not touch upon them at all, are the vaccine, that's called Sipuleucel T, and the other bone-seeking radioisotope called RAD223, which is also useful in patients with castrate-resistant bone-only metastasis prostate cancer. So these are two things that we will not talk upon today in our discussion. Now this is a diagram that shows you the phase 3 trials in metastatic castrate-resistant prostate cancer, wherein there is an overall survival advantage for treatment. Now life was quite easy because we used to divide patients into two groups, and the divider clearly was docetaxel. So you could have a pre-docetaxel phase or a post-docetaxel phase. So Sipuleucel T, abiraterone and enzalutamide could be used in the pre-docetaxel phase. You could use abiraterone, enzalutamide and cabazitaxel plus minus RAD223 in the post-docetaxel phase. But life has become a little bit more complicated for the prostate cancer physician because now we use chemohormonal therapy upfront in patients with advanced prostate cancer rather than waiting for them to become castrate resistant and then putting them on docetaxel later. How does this complicate? Because when docetaxel goes up, all of these other treatments are kind of bunched together, and really you don't know what is the sequence that's the best in that particular clinical setting. And we will try to look at studies, cabazitaxel in particular, and look at where it is in terms of chemotherapy sequence in patients with castrate-resistant prostate cancer. Now, sequencing is an art, so there are no set rules here. So we have to clearly understand that today, survival is clearly dependent upon the number of treatments that a patient can access. So the more the number of treatments, the greater the survival is likely to be. So like in any other disease, prostate cancer is a disease can run a long course. So if it's running a long course, you could follow two paradigms. One is start with the most aggressive agent or the most toxic agent and then go down to the less toxic therapies, or the other way around where you say that you want to start with the less toxic therapy and go to the more toxic therapies later. Now when I say toxic, we are talking about hormonal therapies as the less toxic agents and chemotherapy as the more toxic agents. But at the end of the day, it is important to remember that it is not one or the other, but it is one after the other. Because we said that the more the number of treatments you are able to use, the better is the survival for this patient. In the future, we may have trials where it is likely to be one plus the other. And we've already started that approach in the form of chemo-hormonal therapy, which is what is the standard of care for patients with newly diagnosed advanced prostate cancer. Now, if you look at where cabazitaxel stands as of today, it now is in the second line therapy, which means we use cabazitaxel post-docetaxel. So in this setting, what are the so-called competitors for cabazitaxel? So you have abiraterone, you have enzalutamide, both of which are hormonal therapies, and then you have RAD223 or Alsimca, which is a bone-seeking isotope, which has, in patients with bone-only metastasis, shown to improve overall survival. So you could have many of these sequences that I have listed there, starting with docetaxel, hormonal therapy, chemotherapy, or it could be docetaxel, chemotherapy, and then hormonal therapy, or a mix or match of both. So the question we will be asking is, should after docetaxel, should you be using a hormonal therapy or should you be using cabazitaxel? And it is not based on gut feeling, ladies and gentlemen, that you decide what the therapy is. It is dependent on multiple factors which starts from the patient, the disease, and the access to various treatments that are available, and that's what we will address through this talk. Now this is cabazitaxel for you. So cabazitaxel is a taxane. where the hydroxy group is replaced by the methoxy group. So when this happens, it's important to understand that it does not bind to P-glycoprotein, which is a surface protein or a transmembrane protein, which actually throws the taxane out of the cell. Like most of the taxanes, it prevents polymerization and depolymerization of the microtubules. Unlike docetaxel, cabazitaxel penetrates the blood-brain barrier. There is faster transfer into the cancer cell and longer retention of the drug inside the cancer cell. And very important that most of us forget that these chemotherapeutic agents are not only cytotoxic, but they also have effect on the androgen receptor. Now, generally we believe that the hormonal therapy and chemotherapy are two different arms of treatment and that they don't get mixed up together. But it's important to understand that both cabazitaxel and docetaxel prevent the translocation of androgen receptor into the nucleus, and that's partly one of the reasons for the cross-resistance between androgen therapies or androgen deprivation or anti-androgen therapies and chemotherapy. So this function of chemotherapy is seldom remembered when we are talking to patients and looking at clinical trials of prostate cancer. So before we learn how to position the drug, it's important to first look at the TROPIC study, which is the registration study for cabazitaxel in patients with castrate-resistant prostate cancer. Now let's go through the randomization and the selection criteria for this study. So the study was on metastatic castrate-resistant prostate cancer patients who have progressed either during or after docetaxel-based regimen. So this was a multi-centric study. It was in 46 sites in 26 countries. So the study had almost 800 patients. They were randomized to two arms. One of the arms was the cabazitaxel arm. The second arm was the mitoxantrone arm, because that was the standard of care post-docetaxel as far as chemotherapy is concerned. So you could take cabazitaxel 25 milligrams per meter square once every 3 weeks, or mitoxantrone 12 milligrams per meter square once every 3 weeks. Both arms had prednisolone 10 milligrams that patients took every day. The primary endpoint of this study was overall survival. So let's look at what happened. So these are the baseline demographic characteristics in this study. You see that the median age of patients is 67, and it is equal in both the arms. You see that the number of patients or the percentage of patients more than 65 is significant. So the ECOG-PS, the disease site, measurable disease, everything was very well balanced on this study. If you come to the bottom of this chart, you see that a quarter of all patients in both arms had visceral disease, and about half of all patients had lymph node disease. We do understand that patients with visceral disease or lymph nodal disease have worse biology compared to patients who have bone disease only. And 80% of all patients in this study had bone disease. Now, very interesting to note that a toxic drug, at least a so-called toxic drug like cabazitaxel, the median number of cycles that patients took was 6. You could take up to 10 cycles on the study. And as you will note on this table, the dose intensity was excellent, and there were very few dose reductions or treatment delays, as you see that it's all less than 5%. So this is the primary endpoint of the cabazitaxel study. You see that the primary endpoint, which is overall survival, was met. It was 15 months on the cabazitaxel arm and 12.7 months on the mitoxantrone arm. Now, all of us understand that the absolute numbers are not what you use to interpret a Kaplan-Meier curve. This hazard ratio and the risk reduction is important to understand. So patient on the cabazitaxel arm had a 30% risk reduction in terms of dying because of the disease compared to patients on the mitoxantrone arm. So that's what is signified by an hazard ratio of 0.7. These are long-term survivors. It's interesting to note that even at the end of 2 years, about a third of patients were still alive on the cabazitaxel arm compared to only around 17% on the mitoxantrone arm, clearly showing that the benefits are quite sustained, and it's not that the Kaplan-Meier just separated a little bit in between and then came together. So the benefits in terms of risk reduction of dying is going on and is still robust at the end of 2 years. This is the progression-free survival. Again, almost 3 months for cabazitaxel, 1.5 months for the mitoxantrone prednisolone arm. Again, the value is quite significant. Now, whenever you look at a study like this, what do all of us do? We try to dissect out and see if there is a group of patients who are likely to benefit more or less from the drug. You see that on this forest plot, the median is all or on the left of the median. The center point is to the left of the median, saying that there are no specific groups of patients who benefit more or less from the drug. Now we look at some other subgroups. Whenever we look at a patient who goes on a second-line treatment in prostate cancer, we look at the prior duration of response to androgen deprivation therapy. Because shorter the duration on androgen deprivation therapy, the worse is the outcome. You see that if you divide patients into less than 2.5 to 5 years and more than 5 years, the patients who were on androgen deprivation therapy for the longer period seem to be benefiting higher. You see that it's 20.5 versus 15 compared to 12 versus 8, depending on the duration of treatment on the anti-androgen treatment. So longer you are, the better it is. Again, whenever you look at somebody with a higher Gleason grade, you tend to associate that with a poorer overall survival. But you see here that the poor prognosis because of grade is actually overcome by using cabazitaxel. Whether it's poorly differentiated or well to moderately differentiated, you clearly see that the overall survival is the same 15 months whether in either groups of patients. You see that that is superior to what can be achieved on patients in the mitoxantrone arm. So patients whom you think are not great candidates for androgen deprivation therapy or a second-line hormonal therapy are really good candidates for cabazitaxel-based treatment. Now this is the response rate on cabazitaxel, that's around 15%. These are the radiological responses. If you look at PSA responses, which patients are very interested in, that's around 40% on the cabazitaxel arm compared to about 18% on the mitoxantrone arm. Now, as we started by saying, the other competitors for cabazitaxel in this setting are abiraterone plus prednisolone or enzalutamide. You see that the numbers in terms of median overall survival, progression-free survival, overall response rate and the PSA decline are very similar when you look at cabazitaxel prednisolone versus abiraterone prednisolone. Enzalutamide seems to be having slightly better numbers compared to these two, but as we always say, these are just to give people an indication of what these numbers are, not really to come to conclusions that enzalutamide is a better drug compared to cabazitaxel or abiraterone prednisolone. Let's look at the differences between the cabazitaxel and the abiraterone study. Because we said both of these have equal numbers. Now, abiraterone has been widely available in our country for the past few years, while enzalutamide has just been introduced into the market. So when we say that cabazitaxel and abiraterone have similar numbers in terms of trial outcomes, it's actually not as simple as what all of us think it is, because the trial design was a little bit different. The definition of the endpoint, which is progression-free survival, was different in the cabazitaxel study compared to the abiraterone study. Now, when you look at the cabazitaxel study, the progression-free survival is marked as achieved if your patient has any one of these, if the PSA starts rising, if the pain scores start worsening, or if you have clinical or radiological worsening, then you would say that a progression-free event has been achieved. While on the abiraterone arm, it's a composite endpoint that we try to achieve. That means if one of those endpoints or parameters fail, we don't still take the patient off the study. You want this composite endpoint to be reached in order for patients to go off the study as to be counted as a progression-free event. And it is elementary to understand that a composite endpoint is much more difficult to achieve, and hence you would keep your patients longer on the study compared to every individual of these criteria which would be counted as an event. So if you just look at radiological progression-free survival, it's about 8.8 on cabazitaxel versus 5.6. Nearly two-thirds had discontinued previous docetaxel therapy due to disease progression. So these were patients on cabazitaxel, and this was less than half. We all know that lack of response to a particular therapy tells you that the biology is aggressive. And the patients who went into the cabazitaxel study were with higher or poorer disease biology compared to those who went on into the abiraterone study. And finally, if there are about 26 countries that are participating, the difficulty in managing patients, getting best investigators to manage patients in 26 countries is much more difficult than what you get in 13 countries. So just to cross-compare and try to dissect these trials to look at whether one is better than the other, even though the level playing field was not there, the numbers were very similar between cabazitaxel and abiraterone. So it looks like cabazitaxel might score a little bit over abiraterone based on these parameters that we have shown. So this is getting back to the TROPIC study. In terms of safety events, about 40% on the cabazitaxel arm, these were serious adverse events, compared to half of them on the mitoxantrone prednisolone arm. If you look at the most important adverse events, there were three. One is febrile neutropenia, the other is diarrhea, the other is fatigue. Now you would see, as I have highlighted on the right side of this slide, that the febrile neutropenia rate was 7.5%. Now that's not too high comparing many other regimens that we use, and please understand that at the time of study entry, primary GCSF prophylaxis was not permitted on the study at all. In spite of that, you had only a 7.5%. The other major problem that was reported on the study was diarrhea, and there were few diarrheal deaths also. We'll get on to analyzing those deaths in the next couple of slides. Now, after the initial Data Safety Monitoring Board meeting, because of the initial deaths that they saw due to febrile neutropenia, then they started saying that patients who either satisfied any of those criteria for GCSF prophylaxis as defined by the ASCO guidelines could get prophylactic GCSF. And you clearly see on this slide that without GCSF, the grade 3 neutropenia was double that but when you used prophylactic GCSF. So the other thing to understand is that the incidence of grade 3, grade 4 neutropenia, febrile neutropenia, and deaths due to neutropenia are highest in the first cycle or two. Now this is very similar to many other regimens that we see, and the most common one that you see the same phenomena is CHOP, used for non-Hodgkin's lymphoma. So again there, the incidence of neutropenia, febrile neutropenia, death due to neutropenic sepsis is higher in the first cycle. So it is important to understand this and use prophylaxis right from the beginning so that you have lesser chance of your patient getting into febrile neutropenia and a catastrophic event while on treatment with this drug. So first cycle neutropenia is something that we have to keep a watch upon. Use primary prophylaxis at least in most of your patients with cabazitaxel. we will look at other ways of decreasing the toxicity as we go by. Now, these are fatal events on the tropic study. You would clearly see that the incidence of fatal events is higher on the cabazitaxel arm compared to the mitoxantrone prednisolone arm, and 4 of these deaths were cardiac deaths. Having said that, it was later reported that none of these deaths were related to the drug at all. So, diarrheal deaths were related to the drug. Febrile neutropenia obviously was related to the drug, but the cardiac deaths that were reported in the study later were analyzed and determined that they were not related to the drug at all. So, you could probably come down on that percentage that is marked on the slide in terms of drug-related deaths on the cabazitaxel arm. Having said all this, it's very important that when you're using a drug in a setting where cure is not what we are trying to achieve, quality of life is extremely important. And you see that as the number of cycles go by, we see that the quality of life is actually getting better. So the longer you treat or you can treat your patient, there aren't any cumulative side effects which tend to hamper quality of life. So if you get off those first couple of cycles with primary prophylaxis, keeping a closer watch on your patients, you see that you're able to keep your patients longer on the drug. There aren't many cumulative side effects and the quality of life tends to improve later. This is also quality of life. You see that most of them are quite better as the drug keeps happening, and as you keep getting your patients exposed to more of the drug, you see that the level of all these events keeps going down. It doesn't matter whether it's anxiety, mobility, pain and discomfort, self-care, usual activities of daily life, whatever it might be, it looks like that patients on the cabazitaxel arm seem to be getting better on all these parameters as we go by. Now, we are clear that cabazitaxel is a drug to be used post-docetaxel. Now, that's where we are placing it at this point in time. We are also concerned about the toxicity of the drug. So, we are now trying to ask 2 different questions. The first question is, keeping toxicity in mind, we are asking, is it necessary that 25 milligrams per meter square should be used at all? Because that is the dose in the regulatory tropic study which was associated with toxic death. The second question that we are trying to ask is it better than docetaxel at all? Because when we spoke about the basics of this drug, we said P glycoprotein can't throw it out. We said it gets into the blood-brain barrier, polymerization, depolymerization. So at least on paper, it seems to be a better drug than docetaxel. So it's important to look at, is it actually a better drug in the clinic also, and can a lower dose be used keeping in mind the toxicities that were there on the tropic study? And that's what the first TANA study tried to answer. Patients were randomized again to 3 arms. These are castrate-resistant patients, but they are chemo-naive patients. That means they have not been exposed to docetaxel for their advanced prostate cancer. Patients were randomized to 3 arms. The first arm was the arm which was cabazitaxel, and that was 20 milligrams per meter square. The tropic arm was the second arm, which is 25 milligrams per meter square, and the third arm is the classic docetaxel arm, which is 75 milligrams per meter square. All of these also had prednisolone 10 milligrams every day. The primary endpoint was overall survival. Again, you see the median age is almost 70. In this country, when you look at patients with advanced prostate cancer, you would probably be seeing them a decade earlier, and they are younger patients compared to what went on the first TANA study. Now, if you look at the number of treatments that they had received earlier, it's balanced. About a third of them had more than one. The median number of cycles of treatment, again, is quite phenomenal. You see that the median number of cycles that patients received were about 9. Now, in our day-to-day practice, that average number would be somewhere between 5 and 6. So, it just tells you that if you're able to keep them on the drug, you could go on for 9 cycles, 10 cycles, and so on. It's also interesting to look at the dose intensity, the mean relative dose intensity, which is more than 90%, which I think is really good, because if you really want to get the best out of your drug, you need to keep the dose intensity up, and it looks like most patients had good dose intensity on the first DANA study. Now we'll start by looking at response. The overall picture is that the PSA response wasn't any better in either of these arms. But it's important to note here that the radiological tumor response was better for the cabazitaxel 25 milligrams compared to docetaxel. So this is a comparison of docetaxel versus 25 milligrams of cabazitaxel. Now these two arms are not compared, but numerically you would see that the cabazitaxel arm had a higher response compared to the 20 milligrams. So there's one place where a higher dose seems to be scoring over classic doses of docetaxel and a reduced dose of cabazitaxel, and that is the response rate. This is the progression-free survival, which is one of the secondary endpoints. You see that the curves are really sitting one on top of the other. So in terms of progression-free survival, no difference between the three arms. These are again curves that are kissing each other. Overall survival, no difference between the three arms. So in terms of response, there's some advantage to the higher dose. In terms of progression-free survival and overall survival, there's absolutely no difference. Now let's look at what happens to this toxicity, because we started by saying that one of the reasons we are trying out a lower dose of cabazitaxel is because of the toxicities with the 25 milligram. Let's see if with experience over time have we learned to manage these toxicities better. Now a cursory look at the slide with the highlighted area that I have shown will clearly tell you that like in the TROPIC study, the grade 3-4 adverse events were higher on the higher dose of cabazitaxel, which was also the case as far as discontinuation is concerned. 25% of patients on the lower dose of cabazitaxel discontinued compared to about 31% on the 25 milligrams. But if you look at 25 milligrams of cabazitaxel versus docetaxel, you see that there is absolutely no difference in terms of discontinuation. Again, febrile neutropenia rates were numerically higher in the cabazitaxel 25% arm. Hematuria for some reason was higher in cabazitaxel. But if you look at peripheral neuropathy and edema, that was higher on the docetaxel prednisolone arm. Now please remember that these are not grade 3-4 peripheral neuropathies and edemas. These are toxicities that happen in more than 5% of patients. So what was seen in the TROPIC study was reproducible, or the same thing happened in the first DANA study in terms of toxicity. Cabazitaxel produced more febrile neutropenia, it produced more diarrhea, but docetaxel produced more peripheral neuropathy and edema. Looked like the cabazitaxel 20 milligrams was much lesser in terms of toxicity. Now this is a graph or a slide that is showing the grade 3-4 hematological toxicity. Now I have highlighted the 20 milligram arm here primarily because you will see that the 20 milligram cabazitaxel arm is the one that had the least number of grade 3, grade 4 lab abnormalities in terms of hematological toxicity. It was almost half of what you get on the docetaxel prednisolone or the cabazitaxel arm. Death within the last 30 days after dose was almost similar, and any death during treatment was almost similar. So the 20 milligram cabazitaxel arm looked to be the most favorable in terms of toxicity in this study, which is the first DANA study. So there are many conclusions that the investigators came up with. But I think what is important is this, that cabazitaxel is not superior to docetaxel in terms of overall survival. The lower doses are as effective as the higher doses, but with much lesser toxicity. And based on the first ANA study, the sequence of treatment does not change. That means based on this study, you don't take cabazitaxel up. The lower dose of cabazitaxel is associated with lesser toxicities. So that's what is the carry home from the first ANA study. The docetaxel remains first, cabazitaxel comes after docetaxel. At least based on the study, you don't have to change the sequence of treatments. Now this was another study that was shown in ASCO this year. This is called the Procelica study. Now this was again comparing 20 versus 25 cabazitaxel, trying to prove that 20 was non-inferior to 25, but this is in the post-docetaxel setting. Again, clearly, whatever you saw on the first ANA study is reproduced here. Response rates are better. Toxicity is higher with the higher dose of cabazitaxel. So we now have two studies clearly to show that 20 milligram is as good as 25 milligram in terms of progression-free and overall survival. 25 milligram has better responses. 20 milligram has better toxicity profile compared to the higher dose. So then, how do you really end up choosing these, right? So, when you look at patients who go after the first line treatment, you have to first decide whether patients go on chemotherapy or do patients go on a hormonal therapy. Now, how do you decide this? So, if somebody has had a long run on a hormonal therapy, which is androgen deprivation therapy, if somebody has a lower Gleason grade, if somebody has skeletal metastasis only and had an excellent response to the androgen deprivation therapy, that means your PSA came down to normal, which all signifies a highly androgen sensitive disease and also an indolent disease, then they may be patients for a second round of a hormonal deprivation therapy. But if you, on the contrary, had a patient who is highly symptomatic, sometimes asymptomatic, if the Gleason grade was higher, if the response to androgen deprivation therapy was shorter, the PSA is rapidly increasing, lots of visceral metastasis, then they are probably not good candidates for a second line hormonal therapy. They are candidates who should be going on either docetaxel or cabazitaxel. If they have not been on chemo-hormonal therapy, then they should be going on docetaxel. If they have already been on chemo-hormonal therapy, then they should be going on cabazitaxel. So that's how you try to distinguish as to which treatment you go with. Should you be taking chemotherapy or should you be taking abiraterone or enzalutamide in patients who are on castrate-resistant prostate cancer. Now, there are certain other data to say that if you use cabazitaxel a little bit earlier during your treatment sequence, then you can keep patients on abiraterone and enzalutamide and so on. Now, this is a community-based study that looked at patients who had taken docetaxel and then went on to first receive either cabazitaxel or abiraterone. And when they progressed, patients on cabazitaxel went on to abiraterone, patients on abiraterone went on to cabazitaxel. You will see here very clearly that those who went on cabazitaxel had a greater chance of getting into the next line therapy compared to vice versa. Patients who were on abiraterone had a lesser chance of getting onto cabazitaxel when they progressed on the hormonal therapy. If you recollect, we started by saying that overall survival is likely to be dependent on the number of treatments that patients take. So, if you stopped with one line of therapy, your survival obviously is likely to be lower, while if you went on from one to the other, your survival is likely to be better. And this study, an observational study, is to show that greater number of patients who took cabazitaxel went on to abiraterone versus vice versa. And this is again a community-based study that patients who took cabazitaxel before abiraterone had a better outcome compared to those who took abiraterone first and then went on to cabazitaxel. So this is something that's important to discuss with our patients and also keep in our minds before we take decisions for patients who have castrate-resistant prostate cancer and have progressed on docetaxel. Now this is a little bit of a busy slide, but what I want you to understand is that you get the best returns out of your first and second line therapy, irrespective of what it is. If you recollect again, we said that patients on cabazitaxel or docetaxel also have some cross-resistance to anti-androgen therapies because these chemotherapies also prevent translocation of the androgen receptor. So if patients are on abiraterone or enzalutamide, their response to the next line chemotherapy is likely to be lesser. Patients who have had resistance to chemotherapy have a lesser chance of responding to abiraterone or enzalutamide. So as you go from one therapy to other on the sequence, you clearly see that the progression-free survival, the responses, everything goes down in terms of numbers. So this is to say that you have to be very judicious and prudent when you choose your therapies because it's not trying to be very gentle on your patient. You have to make the most appropriate decision so that you use the best therapies up front because as you go down the line, you are likely to get diminishing returns out of one successive therapy after other. Now, I'm not trying to say that you shouldn't be sequencing treatments one after the other. I'm trying to stress upon the point that you should choose the best possible and the most appropriate treatments that are likely to get your patient the best response upfront, not keep those guns for a rainy day at all. So based on all that we have seen, you could look at many of these sequences. So I have tried to look at two clinical situations. The second clinical situation I will show you in my next slide. Now here is a patient who you will approach in the following manner. So at baseline, you would put them on androgen deprivation for sure. You put them on calcium, especially if they have bone metastasis and are on a bone modifying agent, which is zoledronic acid or denosumab. Now, if your patient has not taken chemo-hormonal therapy and they progress on the first line hormonal therapy, which is androgen deprivation therapy, which is either orchiectomy or an LHRH analog or Digrelix, which is an anti-androgen, you then need to choose between abiraterone and enzalutamide or docetaxel there. Now, how do you really choose? We go back to the rules that we said. Higher the Gleason, shorter the response to anti-androgen therapy, shorter the duration, lesser the degree of response, presence or absence of visceral metastasis, all this will help you decide between a second-line hormonal therapy versus chemotherapy. So if the first-line response to hormonal therapy wasn't good, extensive visceral metastasis, extensive bone metastasis, highly symptomatic, these are all patients who probably should be going on chemotherapy rather than a second-line hormonal therapy. Now again, we have mentioned RAD223 here because that is an option for patients who have bone-only metastasis. Now when they progress on either of these, then they go on to the next line, which could be depending on what you've used first. So if your next line therapy is chemotherapy, then cabazitaxel is an option. While if your next line treatment is another hormonal therapy, then you do either enzalutamide or abiraterone depending on what you have used first line. If you've used enzalutamide up front, you will use abiraterone later. If you've used abiraterone first, you probably choose enzalutamide later. And most importantly, please don't forget that even after that, you have some choices as far as treatment. You could just use steroids. You could use estrogens because these are very, very effective treatments that we use on patients with castrate-resistant prostate cancer. So this is one of those sequences that you can use on patients who have not had chemohormonal therapy. So no chemohormonal therapy, consider hormonal therapy again. If not a candidate for a second line hormonal therapy, it should be either docetaxel or RAD2-3. Once either of these options are exhausted, you could then use cabazitaxel or enzalutamide or abiraterone depending on what the second line treatment was. Once you have exhausted this, you could still go on to a third and a fourth line treatment as depicted in this chart. Now the other situation that we come across very commonly now is that patients are on chemohormonal therapy. So what do you do if your patient has already taken docetaxel? So if your patient has already taken docetaxel, then again the same algorithm applies, but it's just that once they progress on chemohormonal therapy, you may use docetaxel if the progression is more than 6 months to 1 year, but most of us, if they are candidates for another line of chemotherapy, would probably choose cabazitaxel rather than docetaxel again. But you would not be wrong if you choose docetaxel, especially if the duration of control was longer. You could also use abiraterone or enzalutamide, especially if the duration of response to chemohormonal therapy was long and the patients were not very symptomatic. Now, once you make this choice, depending on what your choice was, you go on to the third line, which could be one of those hormonal manipulations again, or it could even be docetaxel after cabazitaxel. Now, is there any data to use docetaxel after cabazitaxel? There isn't any large observational study that has been published, but I think we would certainly want to use a drug that we have already used upfront, but patients haven't been exposed to it for a long period of time. And again, once you exhaust these options, you have good old mitoxantrone, estrogens, and steroids. So essentially, it's the same algorithm as the previous one. It's just that here you have patients who had chemohormonal therapy. In the previous one, you had patients who only had androgen deprivation therapy. So I hope that's not very confusing and is reasonably clear. No talk by any medical oncologist today is complete without showing one of those complicated cartoons as I have shown here, which is showing these genomic aberrations. Now these are gene expression profiles. Now I think what the future is that we would probably use one of these gene expression profiles in order to decide what is the most appropriate treatment for our patient. Now we would certainly not forget the patient who is the most important part of this decision making, but it's important to understand that we also like to have some objectivity in the choices that we make, and hopefully in the future one art or something like this should help us make that decision, because we always want more. We don't want to leave it at the point that it is. We want to do better for our patients, and we want to make the right choices for our patients. So, summarizing, cabazitaxel prolongs overall survival post-docetaxel in castrate-resistant prostate cancer. It is not superior to docetaxel in chemotherapy-naive patients. Lower doses of cabazitaxel are as effective as higher doses. The higher doses of cabazitaxel seem to be producing more toxic effects, but they also have better responses. So probably you would use a higher dose in a set of patients who are young, who are highly symptomatic, for whom that higher response rate might matter. Now, it is active in clinical situations where hormonal therapies may not be effective, which is a very high Gleason grade, rapid progressors, extensive visceral metastasis, and so on. Please understand that toxicity is something that we have to watch out for. We did make a mention about the first cycle neutropenia, and it's important to keep a watch on this and probably use GCSF primary prophylaxis in these group of patients. You could also use a lower dose in order to bring down the toxicity level. We did look at the quality of life patterns and said that as time goes by, there aren't any cumulative toxicities and quality of life seems to be getting better as time goes by. Quality of life is preserved and there is even a mild improvement on treatment. But please understand that at the end of the day, the ability to give your patients the right drug at the right time, most importantly, for the right patients at the right place, is what will give you the longest mileage with each of these drugs. And it's important to make these optimal choices at the right time so that you give your patients the maximum benefit and the longest survival with castrate-resistant prostate cancer. With that, I will end. Thank you so much for all who have joined on this webinar. And if there are any questions, we will take those questions one after the other. Right. So, we already seem to be having some questions which we will take. So, this is Dr. Amit Gandhi from Mumbai. The question is, can cabazitaxel be used as first-line treatment as an alternative to docetaxel? So, at least based on the available evidence, we wouldn't want to do that. Unless you're very impressed with the 20 milligram per meter square dose of cabazitaxel, where the toxicity profile seems to be less. But at least based on the endpoints, it doesn't seem to be that docetaxel will be replaced by cabazitaxel at this point. Because I don't see a clinical situation nor a comorbidity wherein you would prefer cabazitaxel to docetaxel unless you're looking at somebody who's already fluid overlogged or somebody who's got peripheral neuropathy and things like that. So the simple answer is, at this point in time, the answer is no. We wouldn't replace docetaxel with cabazitaxel. Now, patient undergoes 4 cycles of cabazitaxel. PSA is down from 436 to 106. Patient is responding good but has low-grade fever. Dengue test has been done after 6 cycles. How many cycles should we continue? This is Dr. Ketaki Moitra from Kolkata. So there isn't any ceiling to the number of cycles of cabazitaxel that you can use, but it's important to make sure that it's not an infectious cause for the fever, because if there is an infectious cause, it is important to make sure that you treat that infection. So in most studies, they have done up to 10 cycles of cabazitaxel. Now, should you be continuing cabazitaxel beyond 10 cycles? If the response is ongoing, patients are tolerating it well, you wouldn't be wrong in doing that. But I think it's important to understand that we don't know whether there is any benefit at this point in time while you continue beyond 10 cycles. So most of us would tend to stop at 10 cycles and give your elderly patient who would be wanting to left alone after such a long treatment duration. So it would be better to stop at 10, but you wouldn't be wrong if you discussed this issue with your patient and decided to continue for a slightly longer period of time. Dosage of cabazitaxel, whether to go for 25 milligrams or a flat 30 milligram or a flat 30 milligram, right? No, I think the dose that you should be using now is 20 milligrams per meter square. You shouldn't be flat dosing, because we see that the 20 milligrams per meter square seems to be a very well tolerated regimen. Now, as I said earlier, 25 milligrams is something that you probably could use on a patient who is young, whose bone marrow reserve is good, there aren't too many comorbidities, and most importantly, it is a patient who needs response rates. The only area where 25 milligrams per meter square scores over docetaxel and 20 cabazitaxel is the response rate. So if response rate is something that's not important, then you shouldn't be doing 25 milligrams of cabazitaxel, because that is associated with greater toxicities. Ideally, you shouldn't be flat dosing. 20 per meter square seems to be an ideal dose if you're worried about toxicity. How to manage the remaining drug for infusion? Can it be stored for subsequent usage? The simple answer is no, because you can't keep it for 3 weeks and use it for your patient again. Why do patients with castrate-resistant prostate cancer become hormone refractory? Are there clones of cells within the prostate which are hormone refractory from the very beginning? This is Dr. Sanmay Ganguly. Absolutely right. So when you look at prostate cancer at diagnosis, most cells are hormone sensitive. There are some cells, it's about 10%, 15% of all cells, which are hormone resistant even at the time of diagnosis. So when you start androgen deprivation therapy, they have dramatic responses because most of these cells are sensitive to androgens. What happens over time is because of mutations and selection pressure, you start seeing that the clone which is actually resistant to androgens right from the beginning starts populating the tumor. So when that population increases, you end up having castrate resistant, and then later due to successive mutations and activation of certain endocrine paracrine pathways, they become resistant to any hormone therapy at all. That's exactly the reason why we started using chemohormonal therapy upfront, because you could then target both of these clones at the same time, and we have clearly seen the benefit of doing chemohormonal therapy. Both the Chartered study and the Stampede study showed that the overall survival is vastly superior when you use chemohormonal compared to hormonal therapy alone. The other thing that happens to some percentage of prostate cancer patients is that from an adenocarcinoma, it changes to a neuroendocrine, a high-grade neuroendocrine carcinoma, which is again resistant to androgens. It probably is also resistant to cabazitaxel and docetaxel. So that is a patient who should probably be going on a platinum etoposide combination. So there are many reasons that we should be looking at this androgen-resistant clone right from day one. Is there any way to biopsy to know or predict whether patients can become hormone refractory or not? Okay, so one of the things that's been published in the New England Journal of Medicine about a couple of years ago looked at mutations in the androgen receptor. So that's an androgen receptor variant. Now, this was not done on tumor biopsies. This was done on a small group of patients who had circulating tumor cells, and we could test those circulating tumor cells for the androgen receptor variant. Those who had a mutated androgen receptor did not respond to either enzalutamide or abiraterone. But this was done in a small group of patients. This was done on circulating tumor DNA and circulating tumor cells. This was not done on tumor biopsies. Hence, although what you are suggesting looks to be very thought-provoking, at this point in time, doing a biopsy to decide on whether to use a second-line hormonal therapy or not is something that we should not be doing. We should base our decision on second-line therapies based on what was the history on the first-line therapy in terms of response, the Gleason grades, symptoms, where is this disease, what does your patient want, and so on and so forth. So we do not do a biopsy to decide on second-line hormonal therapy. What is the reason that prednisolone is used in all chemotherapy regimens? So this is Dr. Dinesh Sinha. Now that's an interesting question. The most important reason why prednisolone is used in all chemotherapy regimens also is that in the regulatory studies, at least when chemotherapy was compared to either hormonal therapies, almost always the hormonal therapy arm also had prednisolone. So if you believed that prednisolone also had some disease activity, which is actually the case, then in order to balance that, you should have prednisolone also on the chemotherapy arm. So that's one reason why we always use prednisolone in the chemotherapy arm. The other reason that we should be using prednisolone is that some analysis that was done, these are retrospective analyses on the PAX studies and the chartered study, is that patients who took prednisolone along with the chemotherapy seem to be having lesser toxicities compared to patients who did not take prednisolone. So one reason is to balance in terms of the activity compared to the comparator on the various studies. The other is probably to go down on the toxicities of chemotherapy in patients who are castrate-resistant prostate cancer. Is the fatality rate greater in case of lymphomas? Dr. Subrata Chatterjee. I think we are having a discussion on prostate cancer. Oh, you're talking about the CHOP regimen that I referred to and the first cycle neutropenia. No, what I was referring to is the importance of looking at first cycle neutropenia. I try to draw an analogy between toxicities of cabazitaxel first cycle and CHOP chemotherapy first cycle. In CHOP chemotherapy first cycle, you tend to have a greater incidence of grade 3-4 neutropenia, greater incidence of febrile neutropenia, greater incidence of toxic deaths. The same happened in the TROPIC study. Greater incidence of grade 3-4 neutropenia, febrile neutropenia and toxic deaths. Hence, I was trying to say that it is important to keep a watch on first cycle neutropenia, because if you did that, you would end up bringing down the incidence of toxicities and, more importantly, first cycle mortality because of the drug. So we do not use cabazitaxel in patients with non-Hodgkin's lymphoma. So please do not confuse non-Hodgkin's lymphoma with castrate-resistant prostate cancer. Why do prostate cancers become hormone refractory from the very beginning? Now, they are not hormone refractory in the very beginning. It's a very, very small group of patients, less than 5% of patients who are hormone refractory from the very beginning. They tend to become refractory over a period of time. So, in order to take care of that early refractory clones is why we are doing chemohormonal therapy rather than hormonal therapy. What is the role of cabazitaxel re-challenge? Okay, so just as we said that you could do a docetaxel re-challenge later, you would not be wrong in re-challenging with cabazitaxel if your duration of response to cabazitaxel was at least 6 months and your patient is still fit enough to take cabazitaxel. So you could re-challenge patients with any of these drugs in the sequence that we have mentioned. It could be docetaxel, cabazitaxel, abiraterone, enzalutamide, though there isn't any data that we have on this issue so far. But you wouldn't be wrong in doing it as long as the response was there for the first exposure to cabazitaxel and the duration was significant. And when I say significant, it is about 6 months at least. How different is enzalutamide compared to abiraterone? Where do you put it in the sequencing? So that is Dr. Namrata. So enzalutamide and abiraterone are two different drugs. Enzalutamide is a more potent irreversible androgen receptor blocker, while abiraterone is a 17-hydroxylase blocker. So one prevents the synthesis of testosterone, the other blocks the activity of testosterone. There aren't any studies which have compared enzalutamide with abiraterone, but when you look at studies and cross-compare them, it looks like enzalutamide probably is a better drug compared to abiraterone. So you could use enzalutamide in two settings. One is before cabazitaxel or after cabazitaxel. You could also use it before docetaxel or after docetaxel. So in a patient who's taken chemohormonal therapy, which means docetaxel and androgen deprivation therapy upfront, when they progress, enzalutamide is one of the choices. While if for some reason you did not use enzalutamide and used cabazitaxel, you could use enzalutamide after cabazitaxel. So, you could place it anywhere in the sequence. What is important is that your patient should be an appropriate candidate for a hormonal therapy. And we did go through the criteria that we would generally use to choose between one or the other many times. Is filgrastim necessary for before cabazitaxel? That is Dr. Samrat Datta. Yes, I would use primary prophylaxis with pegylated GCSF rather than using filgrastim. As we said, very important is the first cycle. So I generally use primary prophylaxis with pegylated GCSF 6 milligram given 24 to 72 hours after cabazitaxel, irrespective of whether I use 20 or 25. If after the first cycle patients tolerate it very well, they have elevated counts, they have problem with PEG GCSF and so on and so forth, I tend to stop that PEG GCSF after the first cycle. But if they have done well, the counts have not shot up, they haven't had problems because of the PEG GCSF, I tend to continue the PEG GCSF even after. So instead of using filgrastim, which is short-acting GCSF, it might be better to use pegylated GCSF, which is better. Cumulatively, it would end up being cheaper and more effective than filgrastim itself. Taxanes decreasing the AR expression should not have prolonged overall survival with chemohormonal therapy. Dr. Rangaraman. I'm not too sure I have understood this question very clear. So Raman, can you send that question across again? So I assume that you're talking about AR translocation by taxanes versus something. Can you please be clearer and send that question back again? So we'll go to the question by Dr. Anant Pai. Is there a role for cabazitaxel in castrate sensitive like docetaxel? Is there any data? No, there isn't any data on cabazitaxel in patients who are castrate sensitive. The first ANA study, which randomized patients to docetaxel, lower dose cabazitaxel and standard dose cabazitaxel, was on patients who were castrate resistant. So we wouldn't use cabazitaxel like docetaxel chemohormonal therapy. We would use it only in patients with castrate resistant prostate cancer. So there is no role, neither is there any data. This is Dr. Deepak. Do we need to continue patients on androgen deprivation therapy once they develop CRPC? If yes, then can we do so with cabazitaxel? So cabazitaxel is chemotherapy. It is not androgen deprivation therapy. So there are some retrospective analysis where they have looked at patients who were castrate resistant, hormonal resistant, continued androgen deprivation therapy versus not. There is evidence that if you continue androgen deprivation therapy while on your other treatments, those patients have better survival and outcomes compared to patients who have stopped their androgen deprivation therapy. So if you have done your orchiectomy upfront, great, you don't have to worry about it. But if your patient is on either an anti-androgen or an LHRH analog, it is important that you continue this treatment till the end, irrespective of whether they are on abiraterone, enzalutamide, docetaxel or cabazitaxel. So you need to continue it and it has to go on. So you can continue your LHRH analog along with cabazitaxel. Can cabazitaxel be considered in a patient who has progressed during treatment with docetaxel? Both are taxanes. Is there any time gap to be considered? Dr. Srividya. Dr. Srividya, the TROPIC study was on patients who progressed on docetaxel. So for patients who have docetaxel resistance or they have progressed on docetaxel and they need chemotherapy, the most appropriate chemotherapy is cabazitaxel. Though both of them are taxanes, they are not totally cross-resistant. As we showed when we compared abiraterone and the cabazitaxel study or the TROPIC study, almost half of all patients who went into the TROPIC study progressed while on docetaxel. So although both of them are taxanes, they are non-cross-resistant to a certain extent. So patients who progress on docetaxel are candidates for cabazitaxel. Are there any CNS related side effects to look into the cabazitaxel as it crosses blood-brain barrier? Dr. Priyesh from Delhi. No, Dr. Priyesh, there isn't any concern of a CNS toxicity because these drugs cross the blood-brain barrier. At least there is no significant clinically relevant CNS toxicity with cabazitaxel that's been reported on studies. So Dr. Piyush Vajpayee from Delhi has asked a question. 16 milligrams for bi-weekly schedule, your experience? I don't have any experience with the bi-weekly schedule. I wouldn't want to do the bi-weekly schedule because we're happy to do the 3-weekly schedule with 20 milligrams per meter square. The bi-weekly schedule will also end up being extremely expensive with the present dosage formulations of cabazitaxel, which is in 60 milligram. So you would end up wasting more than half of your cabazitaxel while if you did 16 milligrams per meter square. In fact, there's a 10 milligram per meter square study on weekly cabazitaxel also, where you end up wasting even more. I think with the Firstana study, 20 per meter square, not toxic. In fact, the data says that it's even less toxic compared to docetaxel with similar activity as docetaxel in terms of survival, progression-free survival and response. So keeping that in mind, I wouldn't really want to put anybody on a 16 milligrams per meter square because it probably wouldn't offer any advantage at all. Okay, so I have been requested by Panacea, who are the organizers today, that we have received almost 50 questions, and due to time constraints, we will have to stop this right away, and hence we will heed to their request and stop this webinar right away. Thank you all for that patient hearing. I want to say that it's been a pleasure being with all of you. There are more webinars that have been lined up on cabazitaxel, its use. In fact, we haven't talked in detail about the toxicity today. We've talked more about the efficacy. We'll probably have somebody else talking at a later date about toxicity, where many of your other questions can be answered. For now, I will say bye-bye, and I hope all of you had a good learning experience from whatever little I could share with you. Thank you so much all for that patient hearing, and most importantly, thank you all from Panacea for making this possible and the reach to the whole country at one go. Thank you so much.